Welcome to The Deep Dive, the show that gives you the essential knowledge you need without you having to dig through all the research yourself. Today, we are tackling a really common point of confusion in gut health, one that can cause a lot of anxiety: the difference between IBD and IBS.
It's such a critical topic. They sound almost identical, and honestly, a lot of the major symptoms overlap, which makes it incredibly confusing for people who are suffering.
Right, and getting it wrong isn't just a small mistake. The paths these two conditions take are fundamentally different.
Completely.
So our mission today is pretty straightforward. We're going to give you that critical shortcut to understanding them. If there's just one thing you take away from this, let it be this: IBD, inflammatory bowel disease, is a structural disease.
Meaning there's actual physical damage. You could see
Yes,
it.
exactly. Whereas IBS, irritable bowel syndrome, is a functional disorder. The gut looks fine on a scope, but it's just not working correctly.
And that one distinction, structural versus functional, is the key. It changes everything. The diagnosis, the risks, the treatment. And when we say IBD, we're mostly talking about Crohn's disease and ulcerative colitis.
So knowing which bucket your symptoms fall into is crucial. It tells you if you need, say, powerful anti-inflammatory drugs, or if you need to focus on diet and stress. Let's start by digging into that confusing overlap.
Yeah, let's do it.
So what are the symptoms that make these two so hard to tell apart at first? Because, both of them can completely derail a person's life.
Well, the things that usually send people to the doctor are pretty similar for both. You've got chronic belly pain, cramping.
The kind of pain that just stops you in your tracks.
Exactly. And then there's the bloating, significant uncomfortable bloating. And of course, the big one is just unpredictable bowel habits. It could be diarrhea, constipation, or it just swings back and forth.
Plus that awful sudden urgency.
Yes, that feeling of I have to go right now. That's common to both.
Okay, so with symptoms that similar, let's get into the physical reality. Let's start with IBD, the structural one. What is physically going wrong in the gut?
So with IBD, you're looking at an autoimmune issue. The body's immune system gets confused, and it basically attacks the lining of the digestive tract.
It's friendly fire.
It is. And this attack causes chronic inflammation, which leads to real physical damage like ulcers, sores, and bleeding. If a doctor puts a camera in there, they can literally see the damage.
And you mentioned IBD as an umbrella term for Crohn's and ulcerative colitis. Are they different in the damage they cause?
They are, and it's an important distinction. Ulcerative colitis, or UC, is a little more contained. It only affects the large intestine, so the colon and the rectum. And the inflammation is continuous.
Okay, so it's one long stretch of inflammation.
Right. Crohn's disease, on the other hand, can be much more widespread. It can pop up anywhere in the GI tract, literally from your mouth down to your anus.
Wow, anyway.
And the inflammation is different too. With Crohn's, it goes deeper through the full thickness of the bowel wall. And it's patchy. You'll have diseased areas, then a patch of healthy tissue, then more disease. We call them skip lesions.
That sounds much more complex. Okay, let's switch to IBS. If the gut looks fine, what does a functional disorder actually mean?
It means the structure is okay, but the function is not. The communication system is off. I like to think of it like the plumbing pipes are all perfectly fine, but the control system that manages the water flow and pressure is completely haywire.
So the nerves and muscles are misfiring.
Precisely. The nerves in the gut are hypersensitive. This causes the muscles to either squeeze too hard and too fast, causing diarrhea, or too slow, leading to constipation. That's why we classify it as IBS-D for diarrhea, IBS-C for constipation, or IBS-M for mixed.
And the number of people dealing with IBS is just staggering, isn't it? It puts the problem into perspective.
Oh, it's enormous. IBD affects a lot of people, maybe 2.5 to 3 million in the U.S. But IBS, we're talking somewhere between 25 and 45 million Americans. It's one of the most common GI disorders out there. A huge part of the population is struggling with it.
Okay, so they overlap, but there have to be clear signs that point one way or the other. What are those definitive red flags that scream, this is IBD?
The red flags all tie back to that physical damage we talked about. If the gut is actively inflamed and bleeding, it's going to produce symptoms that IBS just can't.
Such as?
The most obvious one is bloody or black, tarry stools. That's a direct sign of bleeding in the gut. Then there's unintentional weight loss, a persistent fever, and this profound fatigue.
And that's not just I'm tired, right? Something deeper.
It's a whole different level. It's an inflammatory systemic fatigue that can be completely disabling. It's often linked to anemia from the blood loss, And another big clue is that IBD often shows up outside of the gut.
The extraintestinal manifestations, that
Yeah.
really drives home that this is a whole body immune problem.
That's it, exactly.
Yeah.
Someone might come in with, say, painful swollen joints, like arthritis, or inflammation in their eyes, or specific skin rashes, even painful sores in their mouth. These are all signs that the immune system is on high alert everywhere, not just in the gut.
And you just don't see that with IBS.
Never. With IBS, you might get more gas, some nausea, that feeling of not being finished after a bowel movement, but you will not get systemic inflammation. You won't get blood. You won't get a fever.
What about the pain itself? Can the location give us a clue?
It can be a very strong hint. For ulcerative colitis, because it's in the large intestine, the pain is typically on the lower left side of the abdomen.
Okay.
For Crohn's, well, it can be anywhere, but the most common spot is the lower right abdomen. That's where the small intestine meets the large intestine, a very common site for inflammation.
And what about IBS pain? Is there a pattern to it?
There is, and it's a really key differentiator. IBS pain is usually crampy, sharp, often in the lower half of the belly. But here's the clinical hallmark. For many people with IBS, the pain gets better or goes away after a bowel movement.
Ah, so there's relief.
Yes. That relief is often missing in IBD because the pain is from actual physical tissue damage that doesn't just go away because you went to the bathroom.
This is where the experience for a patient must really start to diverge. With IBD, you know what the enemy is, it's inflammation. But with IBS, the lack of a visible cause must be so frustrating.
It is incredibly frustrating. For IBD, we know it's a mix of genetics, environmental triggers like smoking or stress, and the gut microbiome all setting off this hyperactive immune response. The inflammation itself is the clear target.
But with IBS, it's more like the wiring is faulty. You mentioned that brain-gut axis. Can you expand on that?
Yeah, the brain-gut axis is central to what we think is happening in IBS. It's this two-way communication superhighway between your brain and your gut. In IBS, that highway is full of static.
So signals get mixed up.
Exactly. Normal sensations in the gut, like gas moving through or the intestine stretching, things most people would never even feel. In someone with IBS, the nerves are so sensitive that those signals are amplified and sent to the brain as intense pain.
So stress doesn't just make you feel bad, it physically makes the gut symptoms worse.
It directly fuels the fire. It makes that faulty signaling even more chaotic. And we also see other triggers.
Like food intolerances.
Huge ones.
Yeah.
Especially with something called high FONKMA foods. These are specific types of carbohydrates that are hard to digest, so they ferment in your gut and produce a ton of gas and pain. For a hypersensitive gut, that's a nightmare.
So how does the doctor actually figure out which one it is? For IBD, they have to find that physical damage you're talking about.
Right, so the diagnostic journey is very different. For IBD, we need hard evidence. We start with blood tests and stool tests to look for high levels of inflammatory markers.
Like C-reactive protein.
C-reactive protein, and especially something called fecal calprotectin. But the gold standard, the definitive test, is an endoscopy, a colonoscopy. The doctor goes in with a camera looking for those ulcers and that inflammation. And they'll take a biopsy, a little tissue sample, to confirm it under a microscope.
And for IBS, it's the opposite. It's a diagnosis of exclusion. You're ruling other things out.
It is. If you come in with any of those red flag symptoms, bleeding, fever, weight loss, you're immediately put on the IBD investigation track. But if the scope is clean, the biopsies are normal, and those inflammatory markers are low, then we start thinking about IBS.
And that's where the Rome criteria come in.
Yes, the Rome criteria are a set of standardized guidelines. They help confirm that you've had abdominal pain for, say, at least 1 day a week for the last 3 months, and that pain is linked to changes in your bowel movements. It's about confirming a consistent pattern of dysfunction once we know there's no structural disease.
That initial stool test sounds like it could be a really valuable tool to avoid invasive tests.
It's incredibly valuable. A fecal calprotectin test is up to 90% accurate at ruling out IBD. If that test comes back negative, it gives the doctor a lot of confidence to say, okay, this is very likely IBS, and we can avoid an unnecessary colonoscopy.
Which brings us to why this all matters so much. The long-term consequences of IBD, they're severe.
They are. Because that inflammation goes so deep, the complications can be life-threatening. You're talking about malnutrition, deep ulcers that can form scar tissue and block the bowel, we call those strictures, or they can form fistulas.
Can you explain what a fistula is? That sounds awful.
A fistula it's an abnormal tunnel that the inflammation basically burns from one part of the intestine to another organ, or sometimes right through to the skin. They're very complex and often require surgery.
And there are other emergencies like toxic megacolon.
Yes, which is when the colon gets paralyzed and swells up massively with a high risk of rupturing. And then there's the long-term risk.
The cancer risk.
The significantly higher risk of colorectal cancer. That constant cycle of damage and repair from inflammation increases the risk, so patients with IBD need regular lifelong surveillance colonoscopies.
Whereas with IBS, as miserable as it is, you're not facing those kinds of structural dangers.
Right. IBS will not cause permanent damage to your intestines, and it does not increase your cancer risk. Its complications are all about quality of life, which can be devastating.
Of course. Chronic pain can lead to missing work, avoiding social situations.
And very high rates of anxiety and depression. It's a condition that can absolutely take over your life, just in a different way.
So the treatments must be worlds apart. For IBD, you have to attack that inflammation head on.
That's the only goal.
Wow.
We usually approach it in steps. For milder cases, there are medications called aminosalicylates. For more severe flare-ups, we might use corticosteroids for a short burst. And for long-term control, there are immunomodulators.
But the real game changers have been the biologic therapies.
Oh, they've completely revolutionized treatment. Instead of just broadly suppressing the whole immune system, biologics are incredibly precise. They're engineered proteins that target and block the specific molecules, the specific signals that are driving the inflammation.
And for IBS, those powerful drugs would be useless.
Completely useless and potentially harmful.
Huh.
For IBS, treatment is all about managing symptoms and retraining that faulty system. So we use things like antispasmodics for cramps, laxatives or antidiarrheals, and sometimes even low-dose antidepressants.
But not for depression, right? For the nerves.
Exactly. They can help dial down that nerve hypersensitivity in the gut. But the biggest tools for IBS are lifestyle changes.
Like the low FODFE diet.
The low FODFE diet is huge.
Yeah.
By removing those fermentable carbs, you can dramatically reduce the gas and bloating that are triggering the pain. And then there's stress management, things like therapy, yoga, meditation. They are crucial for calming down that overactive brain-gut axis.
So it's all come full circle. IBD is structural damage, it's inflammation, it's treated with powerful immune-targeting drugs. IBS is functional, it's about hypersensitivity and motility, and it's managed with diet, stress reduction, and symptom-specific meds.
That's the core distinction. And it's why if you are having persistent GI symptoms, especially any of those red flags, weight loss, blood, fever, you have to see a gastroenterologist. You have to know which path you're on.
Don't forget to like and subscribe.